And welcome to the Davies Use Case webinar being presented by Children's National on head injury CT scan quality and safety. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the manager of quality and patient safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes. These awards-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcome resulting from health IT-enabled care delivery. It's my pleasure to welcome our speakers for today's webinar, Dr. Shireen Adabaki, in Children's Emergency Department. She is an Associate Professor of Pediatrics at George Washington University. Dr. Adabaki is an Associate Professor of Pediatrics and Emergency Medicine, George Washington University, and Children's National Health System. Dr. Adabaki's area of expertise is in concussion and knowledge translation. Through her work, Dr. Adabaki has brought national and international recognition to pediatric concussion. Heroes Award for Research, award by the Maternal Child Health Bureau for her leadership in research to reduce unnecessary CT scan and radiation in children with traumatic brain injury. Dr. Adabaki leads the HIT's HITS for Kids program, Health IT Solution for Kids, a national initiative to improve concussion care for children by knowledge translation of evidence-based medicine, harnessing health IT. The program brings the best and health team at the patient's bedside to provide the best medical care to children and engage healthcare providers in mindful medicine. And I welcome you to this presentation, Dr. Adabaki. Right now, let's see. Let's put this on. Dr. Adabaki.
Thank you for this invitation to present our work on head injury CT scan as it pertains to quality and safety and improving the care of children in pediatric emergency departments. I wanted to start with a little background video. Our work was featured on NBC Nightly News a few years ago and talks a lot about the reasons why we want to reduce unnecessary CT scans in the setting of traumatic brain injury and in other cases for children. Using this model and with this concern in mind, we used our electronic health record and health IT innovations to be able to implement prediction rules for CT scan into our electronic health record, and I'm going to present that in detail, but I wanted to start with the background by showing you a clip from the video from NBC Nightly News.
tonight involves a new warning for parents about children undergoing multiple CT scans to help doctors diagnose medical issues and the risk of developing cancer later on in life. As summer rapidly approaches, kids are out of school, doctors will see the usual increase in injuries from kids playing outside, and oftentimes that CT scan is necessary. So now doctors are starting to take a closer look at how often kids get them and the effects of all that radiation. We get our report tonight from our Chief Medical Editor, Dr. Nancy Snyderman.
5-year-old John Frazier is having a CT scan today. His mother, Samantha, is following up on a complex ear and eye condition, and this scan is the best way to make the correct diagnosis.
Only methadone including full code in with connection side.
While CT scans are invaluable, there's also a risk. Unnecessary exposure to radiation can be damaging to growing children, and repeated or high dosages may increase the risk of cancer later in life. Researchers analyzed data in children under the age of 15 who had CT scans between 1996 and 2011. They looked at the frequency and the level of radiation doses and estimated that of the 4 million scans performed each year, more than 4,800 children could develop future cancers.
The largest increase was for abdomen CT, especially in the older children. And this is worrisome because abdomen CT has the greatest radiation exposure and the greatest cancer risk, especially in girls.
Hospitals across the country are making efforts to reduce radiation exposure for their smallest and most vulnerable patients. Dr. Shireen Atabaki's team at Children's National Medical Center in Washington, D.C. has been able to reduce the number of CT scans by about 30% in the past 2 years by carefully evaluating a child's risk based on injury, illness, and medical history.
We look at their mental status. Are they awake? Are they alert? Are they able to talk to people? Do they recognize their parents? And then we look at a slew of signs and symptoms.
This is years.
Dr. Raymond D., Chief of Radiology, meets with parents to carefully weigh pros and cons of their child's CT scan.
Avoid surgery would allow us to avoid other accidents as well. That risk of death is down.
Also, those CT scanners can retrofit them for $150,000 to $200,000, but they have to make that capital investment. And in the meantime, if your child or grandchild needs to scan, ask if it's necessary, Lester, how many slices they really have to image, and frankly, if there are other alternatives, there are always questions.
Good questions to ask. All right, Nancy, thanks very much.
During Childhood Cancer Awareness Month.
Presentation.
Slide after the video. From NBC Nightly News gave you some more context about the local problem on CT irradiation in children with head injury. I'm going to talk to you a little bit more about the specific issues that we were faced with and the problem that we wanted to address. We know what to do with a child with serious head injury in the emergency department. This is a slide of a child with penetrating trauma to the head from a metallic object. The child was seriously injured, and our teams mobilize. We know how to image the child. We take these children immediately to surgery after we stabilize them. Next slide. The issue is more what to do with a child with mild brain injury, concussion. An example is the 15-year-old soccer player on the field who has a head-to-head impact with another player, hits their head to the ground, and has a brief loss of consciousness, gets up and has a headache. This patient is then possibly brought to an emergency department with a backboard and collar, and the question becomes, what do we do as far as evaluating this patient and imaging this patient. Next slide. The most for an injured child is actually head injury. Each year in the United States, there are 5 million children with head injuries and over 1 million emergency department visits for this complaint. We have overall 4 million pediatric CT scans for children under 15 years of age annually in this country, and that's all types of CT scans, not just head CT. Overall, there was a 20-fold increase in CT scan rates over the period from 1995 to 2003. This is data from the Centers for Disease Control. Why scan? Well, there's a risk of lethal malignancies. A cranial CT has approximately the same amount of radiation as 100 chest X-rays. And a CT in the first 22 years of life can lead to a 300% increase in lifetime cancer. This is from patients followed by the National Health Service in England and the National Cancer Institute. We also know that 1 in about 1,100 infants who receive a CT scan in the first year of life go on to develop a lethal malignancy. As a information, the NCI and FDA issued warnings around judicious use of CT scan for children in 2001. As physicians, we received publications and pamphlets. At the time things were mailed. We didn't have a lot of email going on. There was a public health campaign around this issue. Next slide, please. But we had a great deal of variation in practice around CT scanning. Let's say the 4-year-old who's in the playground falls down and hits their head and has a few episodes of vomiting. These children are frequently brought into emergency departments. They're running around. There's a recommendation from somebody to get a CT scan based on gestalt, not really based on any evidence. And often the children have to be strapped down, sedated for the scan, so they're hold still, and we obtain the CT scans. There's a significant cost to the scans, as well as the radiation risk, which I talked to you about. Next slide, please. Because of the variation in this, since the late 1990s, our team at Children's National has focused on trying to create good evidence to provide to physicians in the emergency department setting to allow them to make good decisions about who needs a CT scan in the setting of a concussion and who doesn't. And the reason we do get the CT scan is to rule out or basically find a bleed in the brain or swelling in the brain or something that would require neurosurgery or hospitalization or intubation. And that's the use of CT scan. And we were able to create a preliminary clinical decision rule based on a prospective study of children that we later published and really come up with a decision rule for the decision of who to scan and who not to scan for the concussed child in the setting of the emergency department. I'm showing you this slide not to show you a picture of me, but to show you that from 2001, we have USA Today with the concerns about CT scans in children linked to cancer. We have information in CBS News on the health report, in Newsweek, and the Washington Post, really urging doctors to show some CT restraint based on evidence, rising evidence around the country, the NCI and FDA recommendations to really judiciously and carefully use CT scan in the setting of pediatric head trauma. Next slide, please. To have a decision rule to find a bleeding in the brain after head trauma, we really needed a lot of patience because it is a somewhat rare event. And in 2009, we went to the Pediatric Emergency Care Applied Research Network, a group of investigators. We prospectively created 2 CT decision rules. The decision rules were derived prospectively in 27,000 children and then validated in another 17,000. So 44,000 children overall. There are two prediction rules. One is for children under 2 years of age, and one is for children 2 years old and above. The clinical decision support that was created from this can detect clinically important injury in the brain, as I mentioned, bleeding in the brain, a depressed skull fracture, things that would require emergent neurosurgery, intubation, and basically be life-threatening. The clinical decision support tool, or the decision rules, have a 99.9% negative predictive value in being able to tell that the child does not have this kind of clinically important injury in the brain. So very, very high negative predictive value. And that's the kind of evidence-based medicine tool that you want for doctors to really be able to adopt, because they know it's very safe, it's very effective, and it's been derived and validated in a large, large cohort of children. We published this article in The Lancet in 2009. So when this article published in 2009, we went around and looked at our practice in the emergency department. So we'd had all this information in the late 90s and early 2000s, all these warnings around CT radiation and judicious use of CT in children. In 2009, we had a very robust clinical decision rule, two rules published for children to reduce unnecessary CT scans and help doctors make the decision of who to scan and who not to scan in the pediatric setting. And what we wanted to do is we wanted to be able to implement this into our practice. And we went and looked at our pre-implementation data. At this time, we had the electronic health record that was implemented at Children's National with full CPOE in around 2008. We looked at our CT rates for head injury, and we saw that about 30% of the children with mild traumatic brain injury or concussion were getting CT scans, so close to a third. And we had close to 2,000 head CTs over a one-year period at our institution. Nearly 1,000 of those, 939 of them, had a concussion, so the CT scan was actually negative. And over 92% of the CT scans overall were normal. I just made a mistake.
Yes.
Thank you. Repeat it. Can I go from after CT rates 30%?
Yes, you could go.
We found CT rates for children with head trauma in our institution to be about 30%. So 30% of the cases of children presenting with head trauma to our emergency department were getting a CT scan. There were nearly 2,000 head CTs between 2008 and 2009. Of these, the overwhelming majority were for mild traumatic brain injury or concussion, close to half, close to 1,000. In the setting of concussion, the children that were scanned, over 92% of the CT scans were normal. There were no findings, completely normal brain. Improve after the publication of our PCARN decision rules in The Lancet in 2009. We saw no improvement in practice from 2009 to 11. Now, we were exhaustively talking about these decision rules, publishing them, giving lectures regionally, locally, nationally on the topic. There was a lot of media, and we still did not see any change in practice. This isn't surprising because traditional knowledge translation is slow. That means from the time an article is published to when doctors adopt it in practice, it takes about 10 to 13 years. So that's a long time to wait. And we also found a tenfold variation in CT scan rates between providers in our emergency department. So some doctors were scanning at a much lower rate and some were scanning at a much higher rate. But there was a tenfold variation between practitioners in our own emergency department on who they would scan with concussion, utilize a CT scan for. Next slide, please. As you can imagine, we weren't happy with this and really wanted to shift this paradigm of care for pediatric concussion from CT scan to really judicious use of scans in this setting, only when needed, and then using clinical tools and screen patients for the disease they actually may have, which was a concussion, which would never show up on a CT scan. And so how did we utilize health IT? Next slide. Well, we wanted to optimize concussion care for children in our emergency departments, and this was 2 emergency departments, one at our main campus and one in the inner city in Anacostia. We wanted to take the effective use of clinical data that we had accrued over the years. We had already developed this through research and partnership through the Pediatric Emergency Care Research Network to create some evidence-based medicine. And now we wanted to harness health IT to get this to the patient's bedside very rapidly. We did not want to wait 10 to 13 years to get this information and these prediction tools to the children's bedside. And then we wanted to affect patient care and result in improved outcomes, which included cost reduction. As I mentioned, there's a significant cost to the CT scan and added cost to sedation and a neuroradiologist reading. So it can be over $1,000 per CT scan. Ultimately was to reduce radiation for these children as well. In addition to cost, we were very reducing radiation. Next slide, please. We developed CPOE decision support, and we created a new order in our Cerner electronic health record system that was called CT trauma header brain. Before we had CT header brain order, and we created a order called CT trauma header brain to address the children with head trauma. We can general CT header brain order for other cases, for our neurosurgeons, patients with shunt failure, cranial tumors, things like that, that we did not want them to have to all go to the CT trauma header brain. When you pull up the order, if you could go to the next slide, it takes you to the algorithm for our decision rule for head CT, the 2 algorithms, one for children under 2 and one for children 2 and above. And you have to go through a slew of signs and symptoms. There are some for children under 2, signs or symptoms that they go through, things like the Glasgow Coma score, mental status of the child, presence of a palpable skull fracture, loss of consciousness, occipital or parietal or temporal scalp hematoma, acting abnormally by the parent, or severe mechanism of injury. And we have conditional logic built into the background, then risk stratifies the patient and gives a recommendation to the clinician. So this patient here, for example, is low risk. CT is not recommended. They don't meet any of the high risk criteria, and they don't meet any of the, for CT scan, and they don't meet any of the intermediate risk criteria where we actually recommend an observation instead of a CT scan. And they are low risk, so CT is not recommended. Now, we don't force the physicians not to obtain a CT scan. This is only a recommendation, and they can go on to complete the order for the CT scan, or they can just stop here. On the second page of this, we have the CT algorithm from our paper in the Lancet, because a lot of doctors want to know what this is based on. You know, what is this conditional logic based on? And so it has the algorithm for the 2 cohorts, children under 2 and children 2 above, from our manuscript. We also down here have examples of severe mechanism of injury, which has some verbiage from our manuscript and from our study published in the Lancet that talks about what are examples of severe mechanism of injury. And this is based on feedback we got from our clinicians. Next page, please. So this is the second tab on the CT trauma head order, where the doctor can actually look at the evidence behind the recommendation. And it basically tells us, based on how the patients panned out in our initial study, one for patients less than 2 and those for patients above. If they did not meet high-risk criteria, then we recommended observation instead of CT, and if they only met a few of the intermediate risk criteria, and if they did not meet any of the intermediate or high-risk criteria, they were low risk. That was about 3% of the population in our initial study, and their risk of clinically important traumatic brain injury was very, very low. The same thing for patients 2 and above. Next, please. And created a governance for design and implementation of this clinical decision support into our electronic health record. Next slide, please. Our goal is patient safety, quality improvement, and evidence-based medicine, utilizing health IT to bring the best concussion care to the pediatric patient's bedside. Our goal was to decrease the percent of children with concussion who had a head CT ordered in our 2 emergency departments. We put together a team of subject matter experts in the emergency department setting, trauma, nursing, IT, and education. Radiology was also involved. We had a project manager, an analyst, and a project architect working closely together in this team. Next slide, please. As he's performed pre-implementation, we're close to 2,000. This is for all diagnoses or all chief complaints over a 1-year period. Concussion was about half of that, about close to 1,000 of the patients. And the negative head CT rate in this cohort, or normal head CT rate in this cohort, was close to 92%. And as I mentioned, we had a 10-fold difference or practice pattern variation of CT ordering, from 4% to nearly 50% among our providers. If you look at this graph, you have a representation of the percent rate of ordering a head CT for a child with mild traumatic brain injury or concussion over this 1-year period. And on the x-axis, we have providers, the individual providers, and there is a 10-fold variation between the providers in rates of CT scan. Now, this is a pre-implementation data. Next slide, please. Our approach was to bring together the multidisciplinary team to work on design, testing, and implementing the clinical decision support rules into the EHR workflow. We had also widespread education with web-based training. We worked closely with our IT education department. We had classroom training and at the elbow support for our faculty and staff, and even our trainees. The residents were trained on this as well. Next, please. I'm going to start with the case of a 16-year-old football player with a head-to-head impact and brief loss of consciousness, who is flown in from the football field by helicopter into our trauma bay, backboard on and a collar on. What would happen is the provider would assess the patient. They would use their clinical judgment to determine if a CT was needed. If a CT wasn't needed, they would stop right there. If a CT was needed, the provider, and this was again based on their gestalt only, made this decision. If a CT was needed, the provider would enter the CT scan order, the CT scan would be performed, and the provider would review results in the electronic health record and then act on them. As I mentioned, the majority of the CT scans were negative in this setting, or normal. This process resulted in an approximately 10-fold difference in head CT rate in our emergency department. Next slide, please. The current process after our team's work was that is currently that the provider assesses the patient. They want to determine if CT is necessary. They enter the trauma head CT order. They answer the 6 or 7 associated questions, depending on the age. The system runs risk stratification algorithm from the PCARN study And the patient is categorized into low, intermittent, and high risk, and the strata is displayed for the clinician to see. If a CT scan is necessary, the patient goes on to get it. The doctor can finish placing the order. The CT scan is performed, and the provider reviews the results in the electronic health record. If not, the provider can stop there with the CT scan. Next slide, please. How did this new process affect our outcomes for children with concussion? What was the value derived? Next slide. Well, the outcomes were wonderful. We had radiation and cost reduction. We were actually very pleasantly surprised. Our baseline CT rates were about 30% of the children with concussion were getting CT scans in our two EDs. This is a pediatric emergency department with pediatric emergency department specialists, and we were one of the main sites for the PCARN study. And so people were more aware of judicious use of CT scan, but still acting on their gestalt. So our rates were about 30%. The rates of CT scan for children with concussion in community EDs, general EDs, adult EDs, where children are also seen, can be as high as 70%. And this was from research from our PCARN study as well. So much higher rates in other settings. And the majority of children are actually not seen in pediatric emergency department settings. They are seen in general EDs and community hospitals. That's about 90% of children. Only 10% are seen in children's hospitals. So our rates were already low, but we saw a very nice drop in rates of CT scan for children with concussion. We had radiation reduction. We had a 44% relative reduction in CT scan rate. Before, we had about 1,000 CTs, 27%, to post-implementation of our clinical decision support tool, we had about 444 CTs. That's close to 12%. So we had a 44% relative reduction in CT scan rate, which was very exciting. We also had an estimated cost reduction. We had about 556 avoided head CT scans a year, and at about $1,500 to $1,600 charge for CT scan with the neuroradiologist reading on average, this would yield about a $875,000 cost reduction per year from these omitted CTs, removing these unnecessary CT scans. Most importantly, we had no untoward outcome. We had no visits within 7 days for the same concern. We had no readmissions within 7 days for the same concern, and we had no related deaths. We published this in Pediatric Quality and Safety in 2017. Next slide, please. Demonstrating our pre-implementation rates in the year prior to implementation from January 2010 to March of 2011. If you can remember, the Lancet article published with the initial PCARN prediction rule was in 2009. And if you look, we have no change in rate after the publication of that up until our intervention, which was implementation of the clinical decision support into our electronic health record. Once the clinical decision support was implemented, we gave a 2-month washout period, and we see a drop to the 11.9% average CT rate, and that has been sustained to date. If you can go to the next slide, please. So we followed these patients for another 5-year period, so from 12 to 76 months post-implementation, and we've seen the rate of drop in CT scan have been sustained. For these outcomes data over the preceding 5 years period, we had removed our lowest acuity patients, so our level 4 and level 5 triage patients. Those were our lowest acuity patients. Removing those, we still saw the same effect and still sustained. So we're very pleased with that data. Next slide, please. We also to our physicians. We had mined the electronic health record data for rates of head CT pre and post intervention, as I showed you before. We used the CPOE decision rule to identify children at very low risk of clinically important brain injury who do not require a head CT, and we have feedback to our providers on overall head CT reduction. And this might have helped with keeping our rates low of CT scan. Could you go to the next slide, please? We have a lot of ideas and a lot of work in place for future advancement. Could you go to the next slide, please? Our first goal is to harness health IT in a similar manner for knowledge translation for other diseases of childhood. Through PCARN, we have worked with colleagues around the country to develop an abdominal CT decision rule for patients with abdominal trauma, again, to remove and reduce unnecessary CT scans in the setting of pediatric abdominal trauma. The abdomen has a lot more organs, and radiation is even more harmful than the brain. Also, we want to look at ways to develop clinical decision rules to reduce abdominal CT in children with abdominal pain, where we're looking for appendicitis, and shift using clinical decision rules to more use of ultrasound and other modalities rather than abdominal CT. To reduce other head CT for other reasons, other chief complaints, we to, again, work with colleagues to develop clinical decision support rules and evidence-based medicine to reduce CT scans for children with new onset headaches, seizures, and ventriculoperitoneal shunts. And we have published work in all these arenas with colleagues around the country. And so our next step is to, once we have the best evidence, to implement it into our electronic health records, really harnessing and utilizing health IT. Next step, next slide, please. Go back, please. Our second goal is to harness health IT for knowledge translation to improve quality and reduce costs. So we have implemented our clinical decision support tools into 2 electronic health records in our emergency departments, one at our main campus and one in our inner city campus. And we really want to use evidence-based models into electronic health records, all emergency departments in our region. So a child going to any hospital in our region, DC, Maryland, and Virginia, can get the same good care and judicious CTs for concussion. We want to do this through a citywide collaboration, which we're currently working on, and have presented this work and have the support of our local city council and different wards and different clinicians and leaders in different hospitals around the city. And our future goal is national and international evidence-based medicine dissemination and provider education strategies. Could you hold on just a minute? Our puppy is barking. I think it's too much background noise. IT for knowledge translation to improve quality and reduce costs around our region. What we wanted to do is take evidence-based models and transfer them across electronic health records in our region and throughout all emergency departments in the District, Maryland, and Virginia. As I mentioned before, the majority of children actually present to community emergency departments and not necessarily children's hospitals following any injury, and especially concussion. And we wanted to make sure that there was the same careful and judicious use of CT scan based on the best evidence. And we wanted those tools to be available, the clinical decision support tools and the prediction rules from our PCARN study to be available to all physicians and emergency department providers in these settings to wisely make a decision on who to CT scan and who not to. We have developed a citywide collaboration, and we have the support of the City Council in the District of Columbia, and are speaking to other states in our area to be able to implement these clinical prediction rules into all electronic health records in emergency departments in our region. We're also looking to national and international dissemination of this evidence-based medicine. And again, have interest from colleagues in different states and parents in different states, advocates in different states, and across the world. And we really want to look at provider education strategies, and we're developing curriculum for medical students to incorporate this into their training, use of these evidence-based decision rules. We also have a curriculum for our pediatric residents and really want to look at disseminating this nationally as well. And we were the primary pediatric site for a meaningful use study in Oklahoma and the District of Columbia, funded by ARC in 2015, where our providers were surveyed and really felt the importance and the need for these types of clinical decision support tools, including our CT reduction decision rule, and really wanted those implemented and talked about their satisfaction with having these in the electronic health record. Next slide. As I mentioned when I started, one of our main goals was shifting the paradigm of pediatric concussion care from unnecessary CT scan in this setting to really screening children for the disease they might have, a concussion, and then managing it. We see youth with unrecognized concussion developing serious sequelae and complications, including depression. There have even been a few cases of suicide, school failure, irritability, anger management issues, headaches, insomnia, and many, many other complaints. Often these children will come to an emergency department after head trauma, get a CT scan. The CT scan is normal in most cases, and they're sent home with a diagnosis of strain after injury. And they sit out of school, let's say for a week or two because of headache or dizziness or other problems, just to rest. They return to school in a week or two, develop, again, a headache or nausea, vomiting, dizziness in the classroom setting or out on the field of play, and they are taken to the school nurse. School nurse calls the parents call the pediatrician. They tell the pediatrician, our child was in an ED following head trauma a week ago, got a CT scan was normal. Pediatrician becomes concerned and says, well, now, still having a headache, take the child to the emergency department. Often the children will go back to another emergency department and get yet a second CT scan. So we really wanted to change this paradigm. The CDC funded us in 2009 to create an effective diagnostic tool for emergency departments to screen children for concussion. And we have created education for the outpatient setting and a communication to the school and primary care physician on concussion, what to do about it, how to rest, have gradual return to play, sport, and schoolwork. And this has improved outcomes. We published this in Pediatrics in 2015 and really want to broadly disseminate it for our patients, and have currently implemented the clinical decision support around the concussion research into our electronic health record as well. Next slide, please. We also have developed a mobile app, which we've piloted for patients and families. It's a mobile health solution that communicates via the electronic health record to the concussion screening information, and it allows for patients to be prescribed a mobile app to go home with. It has a concussion checklist with daily reminders to complete the list while they're symptomatic. Once they're symptomatic, it stops sending them text reminders. It also automatically provides secure communication with the patient's school nurse and primary care physician, telling them that the child has a concussion and to modify, again, their school day, play, and schoolwork. Next slide. So overall, children will continue to be children and continue to be active in a variety of ways, and this is very important for their growth and development. Our goal is to bring the best evidence-based medicine to the pediatric patient's bedside, no matter where they are in the department, in any emergency department in the nation, in our region, or around the world. Thank you.
Thank you, Dr. Adabasi, for that presentation. A very, very interesting topic, a very interesting subject. I just want to remind folks where to find other Davies information, more Davies use case webinars and information on how to apply for Davies Award can be found posted at the HIMSS Davies Award website at hims.org/Davies. And